Hello and welcome, everyone. My name is Tess Taylor, and I'm a specialist in the Community Education Department at MDA. We're excited to have you join us for today's webinar, Updates in Research and Care for Becker Muscular Dystrophy. Following this webinar, please stay for a Becker MD Patient Perspectives panel that will provide further insights into resources, medical support, and care from a group of Becker patients who are here to share their time and experiences with us. This learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events, and stick around to the end of the webinar for more specifics on our programming. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. If you are joining us live, please note that all phone lines have been muted, but we are looking forward to your questions today. We have a Q&A session at the end of the webinar with today's presenter, Dr. Patterson. Feel free to type your questions using the chat feature or the Q&A feature as you think of them, and we'll get to as many general questions as we can after the presentation. MDA would like to thank our sponsor, Edgewise Therapeutics, for partnering with us to bring you today's webinar. Edgewise Therapeutics is an invaluable partner to the Becker community, and MDA would like to highlight their recent webinar with MDA that is part of this virtual learning series. We encourage you to view Edgewise's patient advocacy and resources for Becker MD presentation when it becomes available on demand in the coming weeks. Registrants of today's webinar will receive an email when this resource becomes available. For more information on Edgewise Therapeutics and their patient support opportunities, please visit their website, edgewisetx.com. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. Now it is my pleasure to introduce today's speaker, Terry Heiman-Patterson, MD. Dr. Terry Heiman-Patterson is a professor of neurology at Temple University School of Medicine in Philadelphia. She serves as the vice chairman of research and is the director of both MDA's ALS Center for Hope and the Center for Neurodegenerative Disease. In addition to her academic and clinical roles, Dr. Patterson is the president and co-founder of the ALS Hope Foundation, a nonprofit organization dedicated to improving the lives of individuals living with ALS. Her expertise lies in neurology, with a particular focus on ALS and other neurodegenerative disorders. Hi, Dr. Patterson. Thank you so much for being here today. Let me go ahead and stop sharing my screen so that I can turn the time over to you.
Thank you. Thank you very much. I will try to do this as smoothly as possible. Let's see. Okay, come on. There we go. I'm hoping that my initial slide is showing. Is it? Thanks, Tess. It's really a privilege to be here. I actually specialize in neuromuscular disease with a special interest in ALS, and I'd like to say thank you to MDA because I did 4 years of MDA-funded fellowship before entering into academic practice. So thank you, MDA, and MDA does have a commitment to training and research as well as clinical care. So I'm going to talk a little bit about Becker Muscular Dystrophy today, and we're going to talk about, in general, all the diseases MDA covers, just a review so you realize the depth of the things that MDA does. But we're going to focus on Becker's today. I'll talk about the clinical picture, and I'm going to talk about how we differentiate it from Duchenne and the genetics. And then we'll talk about, what the damage is in Becker's, and then what's going on in terms of treatment and research. So MDA, just so, to briefly mention it, MDA covers many neuromuscular diseases, any disorder that affects what we call the motor unit, which is the nerve cell or anterior horn cell, the motor nerves that comes out of the spinal cord and innervates muscle. So you have diseases affecting that nerve cell, diseases affecting the junction between nerve and muscle, and diseases of muscle. And you can see a list of some of the more common diseases over here on the right, but know that there's more than 40 different diseases that MDA has an interest in and supports. Becker's being one of them. And Becker's is what we call dystrophinopathy. And that's what it shares with Duchenne, that both of these diseases are caused by damage to the dystrophin protein, which is an important protein we'll talk about more later in the talk. But basically, it links the cell surface to the proteins that contract the muscle and relax. And therefore, it stabilizes muscle when it contracts and then relaxes so that the cell surface doesn't break down and the muscle isn't damaged. There's no predilection for any race or ethnic group. And the dystrophinopathies, either Becker's or Duchenne, can affect 1 in 4,000 to 6,000 live male births, boys that are born. And you'll understand as we go through the talk that this is called an X-linked recessive, and I'm going to explain why it's seen in males and not females because of that inheritance pattern. The prevalence is, okay, how many people, if I have 1,000 people, how many people would have the disease, or 1 million or 10 million? And the prevalence is less than 10 cases per 1,000 for DMD and less than 8 cases per 1,000, per 100,000 rather, for Becker's. So incidence is how many people are born with it, or, and prevalence is how many people there are across the population. So there's a somewhat variable presentation and progression. The age range of onset can vary. It's generally later than Duchenne, but it's variable and can be anywhere from 5 to 60 years of age, typically more in the teens. It is milder, and that's the hallmark. And we used to define the difference before we knew about the genetics and before we knew about the protein itself. The way we defined the disease was when the boy was able to walk until. And typically, Becker's was milder, and people were at least 16 years old before they could no longer walk, but often it is into adulthood. The weakness is proximal, meaning in the thighs and the shoulders. And typically the neck muscles are spared. And a very common feature, as you can see here, are those big calves. And we call that calf hypertrophy or pseudohypertrophy. You can have other involvement in Becker's, and depending on how sensitive a measure you use, some estimates are 60 to 70%, but this is with really, sensitive ways to measure it. And what happens is that there's scarring or fibrosis in the heart. You can get a heart block and you can get actual heart failure, but it's typically not as severe as in Duchenne. But that's why when we talk about treatment, we're going to talk about cardiac evaluation. You can also have a curve in the back called scoliosis. And, what people don't realize is the smooth muscle involvement in the GI tract, which can cause constipation and other problems. And unlike Duchenne, cognitive involvement is really pretty rare, whereas in Duchenne, you can see cognitive involvement in up to a third of children. The severity of Becker's is really related to the amount of protein that still remains. Remember, I mentioned that Becker's is a dystrophinopathy, meaning that the dystrophin protein is abnormal. And later in the talk, we're going to talk about how it's abnormal. And in terms of the severity, the more dystrophin you have, the better off you are. And the CK which is a muscle enzyme, it's released into the blood. And when there's muscle damage from any reason, including Becker's, that CK goes up. There are some other ways Becker's may not present with weakness, but can actually just present with cramps and muscle breakdown with a leakage of a muscle protein called myoglobin into the urine. It can also present with just the heart involvement or just elevated CK, or simply with muscle hypertrophy, enlargement, or muscle atrophy. So there are other sort of milder syndromes or different syndromes that can present. And this is an excellent recessive. And again, we're going to talk about this in a little bit, but the disease is due to damage to the gene on the X chromosome. Women have two X chromosomes, and the area of damage can be compensated for by the other X chromosome. So, you have one damaged X chromosome, the other's okay. So women are just carriers. They carry that damaged gene, but they usually don't manifest, except for the fact that 22% of women who carry the mutation can show some evidence of disease. And this is really, again, extremely variable in terms of when that might happen, how old the person was, and how much weakness. And they may simply have cramping or muscle pain. They can also, as in other Becker's patients, have the heart involvement. The CK can be high in 50% of people who carry the Becker's type of mutation. And as I said, it's on the X chromosome. And so when one looks at the muscle here, you can see on the right-hand side, that's what normal muscle looks like. What Becker's muscle looks like is you can see the muscle fibers vary in their size. There's scarring or connective tissue, this light pink material that is around the muscle fibers. You can see there's much more of it. And that's the scarring or fibrosis. And then there are muscle fibers that are dying and undergoing what we call a fancy name, phagocytosis. But basically, the cleanup crew is coming and eating up the dead tissue, taking it away for cleanup, the garbage collectors, which we call phagocytes. And so this would be a typical biopsy appearance to Becker's. Now, we're going to take a trip into genetics for a while, and just because I think it's important to understand the difference between Becker's and Duchenne, and some of the strategies, and why some of the strategies we're using in Duchenne are not as applicable to Becker's when it comes to genetic manipulation. But we all have 22 pairs of chromosomes. We get one from dad and one from mom, and then we get an X and a Y. And we always get an X from mom, and dad can give us an X or a Y. And in this block of chromosomes, this person has an X and a Y chromosome in their sex chromosomes. They would be a male. If it was a female, you would have two X's. Now, these chromosomes, they are the blueprint for all our proteins. This is the blueprint for building the house, for building the protein. And the way it works is that each strand of DNA, it's double-stranded, but each side has a sequence of what we call nucleotides, and there are 4 different nucleotides. And that sequence determines what building blocks, which we call amino acids, are going to be put together and how they're going to be put together. And so for every amino acid, there is a sequence of three of these nucleotides, and that codes for an amino acid. And then the sequence of amino acids is what creates the protein. And, I should mention that DNA is splits apart. Remember, I said it's double-stranded, 2 strands. They split apart and they create RNA, which is then translated into what amino acids to put together and how to put that protein together. Okay, so keep that in mind, because we're going to talk about this again. Remember the code: 3 amino acids, 3 rather nucleotides, 1 amino acid, 3 of these. So the inheritance in Becker's is what we call X-linked. So here you see a mom who's a carrier. She has 2 X chromosomes, 1 is damaged. And we have a dad who's normal. He has a normal X and a normal Y. So when you roll the dice, what can happen? Well, mom can give a damaged X chromosome and dad a normal X, and what you would have is XX, which is a daughter, but that daughter would be a carrier. Or mom can give the normal X and dad can give the normal X, and you have a normal, unaffected daughter, not a carrier. In addition, mom can give a damaged X and dad can give the normal Y, and you have a son, and that son carries the X chromosome with the mutation, and that is the son that will manifest Becker's muscular dystrophy. And that's because the damage occurs on an area of the X chromosome that the Y doesn't have and can't compensate for. Or you can have mom give her normal X and dad a normal Y, and you have an unaffected son. And we call this X-linked recessive, and that is the inheritance pattern. And now, so let's talk. Remember, I talked about the sequence of nucleotides that 3 of them code for 1 amino acid. So think of it as a language. It's a blueprint. So here I have words, 3-letter words in a sentence. So each of these 3-letter words would be coding for an amino acid. And so we have here a normal DNA has all you can ask for, right? It does. It's the blueprint of our body. Now, there can be changes. Mutations are a change in this sequence. And you can have a change that is simply, 1 letter that doesn't really change what it sounds like. DNA has all U, it's silent, can ask for it. It's not the normal sequence, but it's silent. It doesn't make a difference. Or you can have a change that totally doesn't make sense. We call that missense. And so DNA has all Lou can ask for. That doesn't make sense. And that would result in a protein that maybe also doesn't make sense. Or you can have a change in which, there's a deletion of nucleotides. And as a result, you get a stop codon and the protein that's made, just that sequence, it stops and you don't get a full-length protein made, and that protein likely will be cleaned up and not result in a full-length protein. That'll be degraded, we call it. Another way a deletion can occur is if there's one nucleotide missing and everything shifts down. So DNA has well, the L is missing, so we get ALY instead of ALL, and then all the way down the rest of the protein, everything's screwed up. We call that a frame shift. And that results in a protein, again, that's kind of nonsensical, and that is abnormal and likely will be degraded. And that frame shift, remember that, because that's one of the things that we've been working on with in Duchenne, which is to reestablish the frame, to band-aid over from here to here so that you don't lose that sequence. So you're missing 1 or 2 amino acids, but everything before and after is okay. And I'll show you an example of that. And then finally, you can have a deletion that doesn't shift the frame. It's 3 nucleotides are deleted. So you have DNA has, all is gone, and you can ask for. So we have 2 words missing, the all you, and that means everything before and after is fine. You just have a piece missing. That's what happens in Becker's. So everything before and after on that protein, all the amino acids are put together, but you may be missing 2. And that protein usually maintains some function. And so now you're hearing the difference in Duchenne, and I'll say it a few times. In Duchenne, the protein that's made is rapidly degraded because it's so abnormal because of these changes. Whereas in Becker's, you still get some protein, it just has a portion missing, and so that it still has some function left. So this is what happens in Duchenne, and this is what happens in Becker's. And again, Another way to look at it, here's a normal protein put together. In Becker's, you have this deletion, but everything on either end of the deletion is okay. In Duchenne, you have a deletion, but the whole reading frame is screwed up, and therefore everything downstream is not made properly. And so, I like to explain this so people understand, the difference. And another way that we really started to understand this was looking at the actual protein itself. So we would mash up muscle and we would run it on a gel in an electric field. And the smaller the protein, the further down it would go on the gel. And so every gel we stained for a protein that would always be there, myosin, and then we stained for dystrophin, and we could look at the difference between what was a Duchenne person and what was a Becker's. And what you see here is exactly what happens. In Duchenne, here's normal. In Duchenne, there's no protein made, whereas in Becker's, there's a protein, but it's a little bit further down the gel, meaning it's smaller. There's a piece missing, and there's less of it. And then when you stain the muscle itself, this is normal muscle. Look at all the dystrophin, that light brown around the cell surface, whereas in a Duchenne or a Becker's, there'll be patchy or no staining of the muscle. And so this is the major difference. And so this is what I was getting at. We read about, and I know how, exciting it is for, in Duchenne, we have these exon skipping drugs that help reestablish that frame. Remember I said out of frame deletion? It's almost like putting a Band-Aid. So here I have the coding regions, and then I have that deletion that throws everything off. Well, if I Band-Aid over it to the next good spot, I can get a protein that's being made that's more like a Becker's protein. Piece is missing, but upstream and downstream, it looks okay. And that's what all those exon skipping drugs are. However, in Becker's, you've already have that. You already have the upstream and downstream are okay. And that's why these drugs aren't being used in Becker's. Now, what does dystrophin do? Why is it so important? And I already alluded to this. Dystrophin is a link between the surface of the muscle, in this left-hand frame, you can see there's the muscle cell surface, and that yellow orangey protein is attached to the cell surface. It links that, and it links it to the contractile apparatus. In the middle frame, you can see the contractile apparatus, and that's what contracts and relaxes when you make a muscle. And if you don't have stabilization between that contractile apparatus and the cell surface breaks down, it leaks CPK, and there's cycles of damage that occur that need to be repaired. And here you can see that in a healthy muscle, here's the dystrophin. It's linked to that contractile apparatus and the cell surface. And in Duchenne, it's gone. And what happens is the surface falls apart. In Becker's, you still have the attachment areas are okay. It still can link. It's just that this long, thin filamentous part of the protein is shorter. And so that, again, is why Becker's is milder. So how do we take care of people with Becker's muscular dystrophy? Well, the mainstay is really a multidisciplinary approach. You not only need the neurologist and medical folks, but you also need rehab. You may need orthopedics. You may need pulmonary, cardiology, GI. You may need mental health and a social worker. And that all has to be coordinated because you have to address all of the manifestations, not only the muscle weakness, but these other things that we talked about that can occur, like the curve in the back, contractures, and cardiac involvement. So it has to be a multidisciplinary approach. In terms of respiratory care, you have to watch and see if, in fact, the respiratory muscles become weak, then you may need to intervene. So we recommend, assessments of respiratory function, that breathing test we call the PFT, at least yearly and every 6 months if somebody's not able to walk anymore. And if there is evidence that the breathing muscles have gotten weak, or there's elevation in the carbon dioxide level from weak muscles, then we need to start to assist ventilation with what we call BiPAP, or non-invasive ventilation. And we also have to make sure that it's really important to get your vaccinations, and not, because if you get sick and you have respiratory muscle involvement, you can go over the deep end very easily and end up with a tube in you to breathe, and maybe not being able to come off that tube and needing a trach. So we want to keep people as clear as we can. And that means using mechanisms like nebulizer treatments with a coughilator and maybe even a percussion vest, but keeping the airways clear and supporting the respiratory muscles with non-invasive ventilation is needed, and protecting from infection. And then, of course, cardiac care. I mentioned the cardiac involvement, and at least a yearly evaluation with a physical and an EKG and an echocardiogram, in some cases, cardiac MRI. And the more sophisticated and sensitive the technique, the more likely you may be to find something. May or may not need treatment, but we have to be vigilant for when folks do need treatment. And then, of course, there's the orthopedic care. We have to worry about the progression of a scoliosis, and you want to also prevent contractures, which are tightening around the joints as people get weak and they're not moving as much. And this is where PT, OT, and rehab come in. Stretching to prevent that, supplying equipment to help with activities of daily living, mobility devices, bracing that you wear at night, or bracing that you wear when you ambulate or walk. All of these are important, and of course preventing falls, because the last thing you want to do is get a fracture and be laid up, because then you decondition and you get weaker and you may not be able to fully recondition. We also need to do weight management, and if somebody is on steroid, and we'll talk about that in a few minutes, calcium and vitamin D to prevent osteoporosis. Again, if somebody is on steroid, and that's, with Becker's, it's not as common, but there are some clinicians who may use steroid in more severe cases. There can be endocrine issues related to steroids, including diabetes, loss of bone mineralization, osteoporosis, impaired growth. And so the endocrinologist becomes very important. And then if there's GI tract involvement, that smooth muscle, then folks can get problems with reflux and constipation, and you may need to have the appropriate laxatives and GERD medicines, Prilosec and so forth. And then, of course, that psychosocial care. It's hard, to be disabled. I'm sure everybody watching this, the challenges, and especially if you're a teenage boy or a young man, that there's a lot that goes on, and it's important to have support in that area. Now, as I mentioned, some clinicians do use glucocorticoids. Certainly it's a mainstay in Duchenne, but in Becker's, really not so much. But there are some clinicians who will use it, especially in more severe cases. We don't totally understand how steroids work, but maybe the decrease in inflammation, certainly in Duchenne, with either prednisone or deflazacort, it does prolong the time that a boy will walk. There's no real firm consensus on regimens, but there are a lot of different ways to give it. And typically the benefits are that strength is better, motor function is better. It delays the loss of the ability to walk, and it may also help with pulmonary function and delay the onset of cardiomyopathy. But there are side effects, which is why in a milder disease, we don't run in and give everybody steroids, especially if they're mild. And some of those, you can see in the right-hand side, all the different body systems that are affected by steroids. with the most common ones being the weight gain, diabetes, bone problems with osteoporosis, the increased weight, and what we call Cushingoid with the round face, uh, acne, problems sleeping, and psychosis. And so all of this can happen. So, we don't use steroids lightly in a milder disease, and that's probably why it's really not used very much. But we're going to talk about a trial of a new kind of steroid with less side effects that's happening in Becker's, and that may really enable us to use steroids in Becker's more with not as much concern for the adverse events. So let's talk about research. Well, one of the tools, and clinical research is not always as exciting as a new drug trial, but it's really important to develop the tools so that when we do clinical trials, we really can do them right. And that's what Mover Hub is doing. It is a registry for people with neuromuscular disease, including Becker's, and really it gives an eye into what's being done in terms of management and the natural history of the diseases, which we need to aid in the development of clinical trials. Because if we know the natural history, that will inform our trial development. We also in Mover can collect genetic data and medical information, and it can also help identify people who would benefit from new therapies and may want to participate in a clinical trial. So for all of these reasons, these registries are really important, and MDA, of course, has supported the Mover Hub that most of us are participating in. So let's talk about clinical trials. I know that that's really, what you want to hear, because for so long, it's always about Duchenne, but it isn't. Now it's about Becker's too. And so we have the Canyon study, which is looking at EDGE 5506, and this is an inhibitor of fast myosin, which is one of the contractile proteins, and it helps to protect muscle from that damage that's done when muscle contracts and relaxes and the dystrophin protein doesn't work quite right. And this study is going to be looking at CK release in Becker's people who are still ambulatory. And if you look at the pictures here, you can see in the upper right-hand corner, that's healthy muscle when it contracts and relaxes. There can be wear and tear, but there's normal muscle repair and things go well. However, in Duchenne and Becker's, with the dystrophin abnormalities, as you get these repeated cycles, there's not as good a repair mechanism, and you get fatty infiltration in scar tissue, that fibrosis that I showed you that occurs. And what the EDGE 5506 is trying to do is to reduce that damage from the repeated contraction and relaxation. In some preliminary work, it looked like functionally, when compared to natural history of Becker's, and that's why natural history is so important in some of these research programs, understanding the natural history of Becker's, when you looked at how folks on study drug did, their change in a functional ambulatory measure, the North Star ambulatory assessment, showed that they were more stable, certainly, than folks over 2 years in the natural history study would be. So we're certainly looking forward to this study proceeding, and hopefully this will be an intervention for people with Becker's muscular dystrophy. And then I mentioned that there's now a steroid that's approved for Duchenne that has less side effects than the classic corticosteroid, and there's a phase 2 double-blind control study of vamorolone in Becker's now, and hopefully it will also show some efficacy and then make steroids a more widespread option in Becker's. Then there's a lot of research going on in the cardiomyopathy, because that is, one of the causes of death, and certainly in Duchenne and also in Becker's, people can present with simply a cardiomyopathy. So some of the research is really aimed at looking at cardiac complications and what drugs are being used. We have standard drugs for heart failure and the overload in the heart. The ACE inhibitors are the technical type of drugs, and angiotensin receptor blockers. And these are drugs that are in use. But what combination works best for Becker's? And that's something that these registries can help, because you can see what people are on and how they do. But also there's research looking at different centers that do a lot of cardiac evaluation and treatment to see what the best options are and what the best combinations are. There's also efforts to develop guidelines for how to manage the cardiac complications of Becker's. And there's the CAP 1002 in development for Duchenne, but this may also be promising for Becker's. And it's really cardiac stem cells that are derived from donor heart tissue and transplanted into people with the dystrophinopathies. And in DMD, the hope is that it will promote tissue regeneration, and preliminary studies have shown some improvement in some heart function measures. And it seems to be best when it's studied when people are early in disease. And so since Becker's is generally milder, if these strategies work in Duchenne, the hope will be that it will work in Becker's as well. And then there's pholistin, or the myostatin inhibition. Turns out, and what you see is our little kind of juvenile looking Hercules, who has a mutation in his myostatin gene. And turns out that when myostatin is damaged, you get in animals as well as in people, you get big muscles. And it doesn't seem to have any other major effects. So that if we could inhibit myostatin, that might help improve muscle bulk and muscle strength. And so the strategy is to deliver a protein called follistatin via gene therapy to people, which is a naturally occurring inhibitor of myostatin. So it's a way to inhibit this and maybe help to grow the muscles or make bigger, stronger muscles in people with dystrophinopathies. Mouse models have showed an overall increase in the body mass and weight, and preclinical studies of intramuscular delivery of the follistatin gene showed safety and efficacy. And there has been a gene therapy trial delivering follistatin in Becker's that showed that early treatment could boost muscle mass and strength. And obviously, we're waiting for further investigation and crossing our fingers that this will also, turn out well. And then something that is really very interesting. There's a protein called utrophin, and utrophin looks very much like dystrophin, and it's normally produced in Becker's muscular dystrophy. And so the concept is, okay, if dystrophin isn't working right, if I increase utrophin, which really has a very similar function, it binds the cell surface and the contractile apparatus, maybe I can compensate. The problem is that as we get older, and utrophin is really only found in young infantile muscle, and as one matures, it's only found at the neuromuscular junction and goes away from the rest of the cell membrane. So that may be problematic. We don't know yet, but recently, Ractogen Therapeutics has gotten orphan drug designation for their RAG18, a small activating RNA. It's an RNA that's aimed at boosting utrophin production. So it's, again, a genetic manipulation that will increase the utrophin with the hope that this upregulation will reduce muscle damage. And certainly RAG18 delivered through a subcutaneous injection has shown some promise in reducing muscle damage. So again, crossing our fingers. Another problem, as I mentioned, is that fibrosis, that scarring around muscle tissue. And you can see it in the right-hand picture compared to healthy muscle, all that light pink scarring. And both Becker's and Duchenne have this scarring where there's inflammation and then replacement of the muscle by fat and scarring or fibrosis. And there's a drug, Givinostat, which decreases fibrosis in Duchenne, and it's been approved. It does slow disease. There was a separate study in Becker's over 1 year, but there did not appear to be an effect on fibrosis. Maybe that 1 year isn't long enough, but in any event, even though that study failed on its primary outcome measure, it did give us insights on how to assess people with Becker's in a clinical trial. And it may have some relevance as to whether or not if something works in Duchenne, will it work in Becker's? And we don't know the answer to that. We think that it might. It really depends on the mechanism. But while we wish it had worked in Becker's as well as it did in Duchenne, we did learn some things from the trial, and that's important for designing the next trial. And so, with that, I'm going to conclude, Becker's is a dystrophinopathy with a milder appearance to Duchenne based on the fact that there's some preservation of the dystrophin protein function. Progress is really being made on the treatment of the complications, and clinical research is really increasing now with the development of assessment tools and a better understanding of the natural history so that we have the tools to do clinical trials. And while not all treatment strategies that are applicable for Duchenne may be applicable to Becker's, some can be leveraged for Becker's, and there's more trials going on, and there's a rising interest in doing clinical research and clinical trials in Becker's, and I think the future is promising. And with that, I will stop. Thank you very much for your attention.
Thank you, Dr. Patterson, for that wonderful presentation. So much great information you were able to provide us. Let me go ahead and switch back to my screen really quick, and then we will do a short Q&A with you. So we do have a few questions for you here. I think we will start with, I am newly diagnosed with BMD. What are some common complications I should watch out for, and how can I help prevent them?
Well, I think the first thing is to get to a good multidisciplinary MDA clinic. I hope that you're not in a remote area where it's difficult, but because that way your care can be more consolidated in that multidisciplinary approach. I think the complications, you want to get your baseline breathing test and your baseline EKG and cardiac evaluation. And then you don't need them that often. If everything's normal, probably yearly, especially if you're still ambulatory, still walking. And then you want to get seen by a physiatrist and PT and OT to maximize your function, because that's really important. You'll want to, be hooked into a neurologist who's knowledgeable about trials, and you'll want to get on the website if you're interested in trials. Not everybody's interested in joining a clinical trial, but you may be. And if you are, there are several places to go. I'm sure there's MDA's website. There's also the nightmare that's NIHclinicaltrials.gov. But, you can look for enrolling trials there. There's a way to do that. That sometimes can be overwhelming when you go to clinicaltrials.gov. But your physician, your neurologist, should be a resource for you. And so, that's where the start is, I think, is making sure that your function is maximized now and getting your baselines settled.
Great, thank you so much. Let's move to another question. how is muscle weakness typically distributed in BMD? So which muscles are most affected?
The thigh muscles, which you're flexing your hip, those muscles, and also the muscles that help you get out of a chair, for instance, we call those the hip extensors. And then after that, the next most common or the next thing is usually the shoulder muscles, specifically the deltoid biceps and triceps. Those are the names, but it's really being able to elevate your shoulders like that. And typically your calves can be quite large, but those get affected later. The feet and hands are later. You want to make sure that if you are weak, you're doing your stretching and exercises so you don't get contractures. And, probably going back to the last question, you want to get a baseline x-ray of your spine to make sure it's not curved.
Great, thank you for that information. So another question for you. How frequently should BMD patients be monitored by specialists, such as a neurologist, a cardiologist, or a pulmonologist?
It's very different, depending on your severity. I basically say, we see somebody at baseline. If they're mild, I'll see them every 6 months, and yearly they should have a breathing test, x-rays of their spine, and an EKG. If those are normal, then I can wait a year. If they're not normal, I'm going to send them to the specialist, and they probably should be followed every 6 months. So there's some individuality. It's not, a set in stone kind of thing. I hope that answers your question.
It does, yes. Thank you so much. Yeah, it does. It varies from person to person, but good to have some kind of baseline for sure. So a couple questions from the chat, and then I think we'll conclude for you. Can we eat healthy to make heart symptoms in Becker's better along with heart medication? So are there any supplements or dietary guidelines that might be helpful?
It depends on if you also have elevated cholesterol or elevated blood pressure. Watch your salt, because one of the problems is cardiac overload. And if you have too much fluid, which is sort of generated by having a lot of salt in your diet, that can make you worse. And the cardiologist, eating a heart healthy diet is never going to be bad, that's for sure. But in general, that would be something that's going to be kind of dictated by what other health problems you might have and what your heart actually looks like. And so, talking to your cardiologist would be appropriate.
Thank you. We have another cardiology related question from the chat. Would you mind fielding that?
I'll try.
Okay.
Guys.
No pressure, but we do like to just at least field the questions from the chat. So my children have heart issues. They are 20 and 22. EF fracture rate of at the last visit was 25 to 30. The heart meds cause side effects. Is there anything that can help on top of medication?
Well, you heard me talk about some exciting trials, but obviously that's trial. It's not out there yet. Unfortunately, the cardiologist will have the list of medications that they can maybe alternatively use. There's usually more than one drug in, for instance, the different kinds of drugs, the beta blockers, each sort of characteristic type of drug. There's more than one drug in each category, so that there may be another drug that has less side effects. So trying to find a similar drug with less side effects would be the starting point. This is hard because you do need to reduce the load. So
yes. Well, thank you for your input. I do think that's helpful. All right, I'm not seeing any more questions in the chat, so I think we will conclude your presentation for the day, Dr. Patterson. But thank you again so much for being here and for your time and your support of MDA and our community. Thank you.
Thank you for inviting me.